Welcome viewers. Now we'll talk about dilated cardiomyopathy. In North America and Europe, symptomatic dilated cardiomyopathy has an incidence of 20 per 1 lakh and a prevalence of 38 per 1 lakh. Men are affected more than twice as often as women. So men are affected more than twice as often as women. What is the pathogenesis of dilated cardiomyopathy? Cardiomyopathy is characterized by dilatation and impaired contraction of the LV or left ventricle and often the right ventricle. Left ventricular mass is increased but wall thickness is normal or reduced. Dilatation of the valve rings can lead to functional mitral and tricuspid incompetence. Histological changes are variable but include myofibrillary loss, interstitial fibrosis, and T-cell infiltrates. The term dilated cardiomyopathy encompasses a heterogeneous group of conditions. Alcohol may be an important cause in some patients. At least 25% of cases are inherited as an autosomal dominant trait, and a variety of single gene mutations have been identified. So 25% of cases are inherited as an autosomal dominant trait. Most of these mutations affect proteins in the cytoskeleton of the myocytes such as dystrophin, lamin A and C, and amarin and metavinculin. Many are also associated with abnormalities of skeletal muscle. Conversely, most of the X-linked inherited skeletal muscle dystrophies, skeletal muscular dystrophies such as Becker and Duchenne are associated with cardiomyopathy. Finally, a late autoimmune reaction to viral myocarditis is thought to be the cause in a substantial subgroup of patients with dilated cardiomyopathy. A similar mechanism is believed to be responsible for the myocardial involvement that occurs in up to 10% of patients with advanced human immunodeficiency virus infection or HIV infection. So now, clinical features. What is the clinical features of dilated cardiomyopathy? Most patients present with heart failure or are found to have the condition during routine investigation. Arrhythmia, thromboembolism, and sudden death may occur at any stage. Sporadic chest pain is a surprisingly frequent symptom. The differential diagnosis includes ventricular dysfunction due to coronary artery disease, and a diagnosis of dilated cardiomyopathy should be made only when this has been excluded. So I again repeat the situation. The differential diagnosis includes ventricular dysfunction due to coronary artery disease. So a diagnosis of dilated cardiomyopathy should be made only when this has been excluded. Now the investigations. What investigations we will do in dilated cardiomyopathy? Echocardiography and cardiac MRI are the most common, most useful investigations. Although ECG changes are common and they are non-specific, genetic testing is indicated if more than one family member is diagnosed with this condition. So I again repeat, genetic testing is indicated if more than one family member is diagnosed with this condition. Now, what is the management of dilated cardiomyopathy? The focus of management is to control heart failure by using the strategies described earlier in this chapter. Although some patients remain well for many years, the prognosis is variable and cardiac transplantation may be indicated. Patients with dilated cardiomyopathy and moderate or severe heart failure are at risk of sudden arrhythmic death. I am repeating, patients with dilated cardiomyopathy and moderate or severe heart failure are at risk of sudden arrhythmic death, and this can be reduced by rigorous medical therapy with beta blockers and either AC inhibitors or ARB. So we will use beta blockers and either AC inhibitors or ARBs. Some patients may be considered for implantation of a cardiac defibrillator and or cardiac resynchronization therapy. Thank you all.